Dear colleagues, dear PCR companions, welcome to PCR webinar on tricuspid valve. This is organized by the PCR Tricuspid Focus Group. And the topic we are covering today is guidelines. They have been freshly released. There are a number of important new things to be discussed. I'm here together with Marta Stiges from Barcelona, with Julien Dreyfus from France, from Paris, Saint-Denis. And there is Jörg Ausleiter from Munich, who is also joining online. I briefly review the learning objectives of these 60 minutes. We want to get familiar with the new recommendations. There is also a very important 2A level of evidence indication for transcatheter valve interventions. We'll anyhow focus also very importantly on how to manage patients with TR according to guidelines. There is a lot which has been implemented in this version of the guidelines. And also we will anyhow discuss some criticism, some gray zones and some of the open issues because we need anyhow to translate these guidelines into clinical practice. Without further delay, I would suggest that we start with the real life. So we will start with Julien, who will present us one case of TR.
Thank you, Francesco. So I will present the case of a 70-year-old female who had paroxysmal atrial fibrillation, no significant comorbidity. She was symptomatic, presenting with NYHI function class 3, no right-sided heart failure sign. She had no significant impairment of liver and kidneys, and she was treated with 80 milligrams of diuretics of furosemide per day. Her tri-score was 2 out of 12, meaning a low tri-score with a low predicted in-hospital mortality. Transthoracic echo showed severe TR. You have to consider that right cavities are on the right side of the screen. So severe TR with dilation of the tricuspid annulus, with dilation of the right atrium, with dilation of the right ventricle, but no impairment of the right ventricle. Transesophageal echo confirm severe TR due to tricuspid annulus dilation. And if we look at the anatomy of the valve, it seems to be a 4-leaflet valve with 2 posterior leaflets and a diffuse jet with a large gap measured to around 8 millimeters after diuretics. This was confirmed with 3D showing the large gap at the posterior level and on the right side of the screen the distal esophageal echocardiography confirming the diffuse jets both anterior and posterior. I would like to precise that there was no disease at the left side, no significant aortic or mitral valve disease, no left ventricular impairment, and that right heart catheterization was performed without a significant elevation of the pulmonary pressure.
Okay, so Marta, this is a quite, I would say, common case that we see in our practice. Maybe 10 years ago, we would say TR is one TR. Today, we need to phenotype this patient. So let's start discussing what kind of patient is this one?
Yeah, so absolutely, Francesco. So first of all, it's a female. We know TR is much more frequent in female, has this previous history of atrial fibrillation. And also from the echo, we can see that there is a very enlarged right atrium and a very enlarged annulus. And also, if we look at the coaptation of the leaflets, they coapt almost at the level of the annulus, not in the ventricle, so no tenting of the leaflet. So this really suggests secondary TR, but secondary to atrial dilatation. And this is an entity that has been recently recognized, where the main lesion is annular dilatation due to this annular dilatation. So to call it one name, we will call it secondary atrial secondary tricuspid regurgitation.
So very, very important definition, by the way, has been probably the first time published by the tricuspid focus group, a paper to kind of delineate this pathology. And obviously this is a patient which has a spectrum of options in front. So we don't know yet, we are blind to the final outcome of this patient. I would like to, before we go into the guidelines, just quickly ask Jörg Hausleiter, when you see this kind of patients, what's the next step? So there is TR, the patient is symptomatic, is an elderly patient with a low surgical risk according to the TRI-score. So Jörg, what's next? What is your next step for decision making?
Well, for the decision making, I think we want to hear a little bit more about the comorbidities, about the lab values. For example, if the patient has some hepatic disease like a cardiohepatic syndrome. We already heard that the patient has no pulmonary hypertension in the right heart cath. Of course, coronary disease should be ruled out. But if we then consider that what has been shown today here in this patient, this is, as you said before, a very typical patient who has multiple options, but the medical option has been already been used for the last time. So probably we want now to see a reduction in the tricuspid regurgitation. So we have probably a surgical option because the patient is not too old and has not a too high risk. But it is also like a typical patient which has been previously enrolled in clinical trials, and we're discussing this later. So I think from this perspective, all the available options from surgery to transcatheter therapies could be applied probably with very good outcomes.
I think this is a webinar with also participants online, and we are very happy to get feedback from the audience. If anyone has a suggestion of what to do and see what will be the outcome of this decision making of the heart team. So Julien, you are collecting eventually the questions from the audience. We are here ready to answer online. On the other hand, again, this is a patient for the guidelines. What the guidelines say and how can we follow the guidelines to take a decision and to treat in the best way this kind of patients. It starts with a structure. And actually, for the first time ever in the guidelines, there is a class 1 indication for assessing these patients in a heart team, in a dedicated multidisciplinary team. And so I would say, Julien, why don't we review what is the content of this, what happens and what should be this heart team specific for tricuspid interventions?
Thank you, Francesco. So I will describe the requirements for heart valve centers with expertise in tricuspid valve treatment. First, we have to remind that patients with tricuspid regurgitation represent a very heterogeneous population with many phenotypes, and Marta described primary, secondary, or lead-induced. So very different phenotype first, and also different impact of the disease on the right ventricle and on other organs such as liver or kidneys. When to refer patient to a heart valve center, this is a very important question, and the answer is timing is key. And that was, it is suggested to refer patient with severe TR or moderate TR if you identify red flags that Marta will describe later, and then you refer your patient to the heart valve center. And as Francesco mentioned, it is the first time that the guidelines consider that evaluation is a class 1 indication, meaning how important it is and how difficult also it is. And you need to perform a careful evaluation in a dedicated center with a multidisciplinary heart team. And when I mean a careful evaluation, it's a step-by-step workup with several different investigations and a discussion with an extended heart team. And when I mean extended heart team, usually we consider a surgeon, an intervention cardiologist, and an imaging specialist, but you have to add also electrophysiologists, you have to add heart failure specialists, and even some other colleagues. So first you perform the step-by-step workup. And then the same heart team will discuss together to define what is the best strategy for each patient and perform this strategy knowing that now we have different options that could be medical, surgical, or transcatheter, and for each intervention there are different types that will be described later. So if we now go back to the requirements of each heart valve center dedicated to tricuspid valve intervention. First point, cardiovascular imaging. You need an expertise in transthoracic and transesophageal echo, both in 2D and 3D. You need also expertise in cardiac CT and CMR. You need expertise in interventional echocardiography with dedicated trained team to guide complex valvular intervention and, if possible, to have a 3D eyes available on site. Second, you need intervention cardiology with extensive experience in valvular intervention and especially in mitral transcatheter edge-to-edge repair, who has also expertise in transcatheter edge-to-edge repair for tricuspid valve, but also transcatheter valve replacement for the tricuspid valve. Third, you need cardiac surgery on site with extensive experience in valvular heart surgery. Fourth, and it is quite new, you need to work together with electrophysiologists who have expertise in pacemaker, CRT, ICD implantation, but also flutter and atrial fibrillation ablation with availability on site of valve-sparing options such as leadless pacemaker implantation, coronary sinus pacing, and if possible, also expertise in transvenous CID lead extraction. You need to work close with heart failure specialists who have an expertise in management of advanced heart failure, especially with valvular heart disease, and also dedicated beds with trained teams about invasive monitoring, especially when you have patients with RV failure who may require support. And then, very importantly, you have to collaborate with colleagues that are not specific doctors and not specific cardiologists. So you need administrative support for your heart valve team. You need dedicated team of cardiac anesthesiologists and also work with colleagues from other specialties. So to conclude, an expert heart valve center dedicated to the tricuspid valve is first an extended heart team who will first perform a standardized step-by-step workup and second decide and organize a tailored strategy for each patient.
Thank you, Julien. I think for us, working in this field, it is granted. But imagine what has been the evolution of this field in the last 5 years only. The PCR tricuspid focus group has been initiated only 5 years ago, and it looks like everything has been changed and evolved. Even the heart team now evolves much larger with a lot of physicians involved in these patients who are often polymorbid. They are elderly. They come also from different pathways. I want to ask you, Marta, first. The big questions today is to refer the patient early. So when somebody in the community, I'm not even talking now to the interventional community, let's talk to the medical community. When do you think a patient should be sent for evaluation? I'm not saying for treatment, but for evaluation of the stage. No, the guidelines say send to a competent center to evaluate the etiology, the mechanism of regurgitation, the stage of the disease, and so when is the right time?
Well, that specific question has not an only answer, but probably we should think on sending the patient, globally speaking, when the TR is moderate and going to severe TR. Why is that? Because we are now in a status that we are sending them too late. So if we prefer to be too advanced than too late in sending the patients for evaluation. So of course that will depend a little bit on our network of referring centers and referral centers. But it depends a little bit on the agreements and on the expertise that they agree to have. So, for example, in some centers they agree, okay, you send me all the severe tricuspid regurgitation. Others, they wait a little bit until the right ventricular function is more impaired. But globally speaking, I would say severe tricuspid regurgitation, or at least moderate tricuspid regurgitation, should raise the red flag together with all the symptoms that we will discuss. And this is a big issue because symptoms of tricuspid regurgitation are not straightforward. And this is indeed an internal medicine disease. So you can find patients who complain of abdominal discomfort, of asthenia. So you have to really think of TR and try to screen the patient to see if he has or she has TR, and also think on the red flags regarding the medical history. So pacemaker, atrial fibrillation, these are kind of risk factors for developing TR that need to be in our mind and need to raise our red flags to send these patients.
So you mentioned something that sounds very familiar to me, that tricuspid insufficiency is an internal medicine disease, because actually it affects all the organs, all the splanchnic organs, and involves actually in the management of these patients the need of a multidisciplinary team that goes much beyond actually interventions. Fabian, there is any question coming?
Matteo, yeah, one question from the audience. Do you think we should refer patients who have severe TR but who are asymptomatic with RV dilation?
At this point, I would say yes. Why? Because we still need to spread a lot the knowledge that we have on tricuspid regurgitation. So even if they are asymptomatic, there might be signs that we will see of already right ventricular dysfunction and dilatation, and these patients probably need to be treated right now. Because we have to keep in mind also that most of our tricuspid regurgitation are secondary, and they can be secondary to atrial dilatation, but also to ventricular dilatation. So at that point, the threshold, let's say, for right ventricular dilatation and dysfunction are already there. So we need to be earlier. So at this point, I would say yes.
So there was one slide which was stating the variability of presentation according to the phenotype. So multiple phenotypes, probably different pathways, different clinical history, different doctors who are referring these patients to our centers, but also probably different centers. So I want to ask a question to Jörg, because Jörg is very much involved in this field, and we talk about specialty centers with multiple options. How important is to have a center of excellence which is equipped with all the options for these patients, including going from medical therapy for heart failure up to transplantation, whatever?
Well, as you can expect, of course, it is very important to treat the patient in an expert center, because we want to have an expert outcome of our patients. And knowing how diverse the etiology is, we need to have very different approaches. We already talked about medical therapy on the one side. We talked about the importance of electrophysiology, about leads which need to be extracted in some patients to improve tricuspid regurgitation, but then also the other options for improving or reducing the amount of TR by either a surgical procedure or a transcatheter procedure. And all of this is integrated in the heart valve center, and it has been shown, as in many other specialties, that the volume is related to the outcome, and this is only going to be possible if we have a very specialized heart valve center who is treating a lot of those patients, so that all of those patients get the best outcome.
We will maybe later you will cover this topic of the multiple options which are available. Having multiple options sometimes is even a challenge, because obviously we are more confused. The community is confused. We don't have yet so much data to to support decisions. There is an evolving scenario of evidence. So that's why probably also we need specialized centers who are dedicated, focus on this disease. They keep up to date to the latest knowledge. They participate to PCR webinars on a regular basis to get informed. And also centers who are able to establish a connection with the community, because as we mentioned before, many of these patients are undertreated or even underdiagnosed, because the symptoms sometimes can be very misleading and can be somehow confused with just aging. Most of these patients are elderly. So it is a complex scenario, but it is a scenario where we have a lot of tools. And I'd like to now go more into the practicalities of the discussion. So we understood what are the tools which are needed, what is the hardware, let's say. So the Heart Valve Center is full of opportunities, but what is the actual workup of these patients? So how does it work, Marta?
Thank you, Francesco. So I think this is a big novelty of the current guidelines, because these are my conflicts. So I think it's a big novelty of the current guidelines because they put this stepwise evaluation of patients with tricuspid regurgitation in this comprehensive way, implicating many professionals, many disciplines, and many evaluations. And here, of course, medical history, symptoms are, as usual, very important to raise these flags, but we have a combination of imaging tests that we will discuss, and also, not only target to depict the diagnosis of severe tricuspid regurgitation, but also to evaluate the impact on right ventricle function and also on the pulmonary circulation. Also at looking the anatomy of the functional anatomy of the tricuspid valve, because as said before, we have different options that may be different for each type, each phenotype, and each anatomy of the tricuspid valve. And also very important, the evaluation of the risk of the surgical risk or the interventional risk of the patient. And we have validated scores for that with the TRI-score and also the STS, but mainly in Europe, the TRI-score. And very importantly, the guidelines put this as a class 1 recommendation. This is a real novelty, first time ever from the guidelines to have this comprehensive approach for the tricuspid valve. And I think this is a very important achievement, and I think sincerely that the tricuspid focus group has done a lot on increasing the awareness of this problem, of this multidisciplinary approach. So another important issue that has been highlighted for all valves, but also for tricuspid regurgitation, is the combination of multimodality imaging, which means combining different modalities, transthoracic, transesophageal echo, and CT and NMR, to really depict and to really describe precisely the severity of tricuspid regurgitation. But more importantly, and again, this is the first time that the guidelines highlight this, because these are different phenotypes of tricuspid regurgitation. So it's really important to understand the underlying mechanism, because each one will have a different approach, including different medical therapies or interventions. To this end, it's important to understand what is the basic imaging, which is, of course, transthoracic echocardiography, basic imaging modality to confirm the diagnostic of tricuspid regurgitation, to evaluate the severity, and to have an idea of the etiology and also the right ventricular function. Secondly, transesophageal echocardiography, more advanced, but probably key to depict the functional anatomy of the valve and the underlying mechanism. And in some cases, particularly when there are doubts, and we can discuss later on when to perform this more advanced imaging, but it's important that we have the ability of these techniques because they are essential cardiac CT to depict the planning of the intervention, particularly for those patients who are being evaluated for percutaneous or transcatheter approaches, and also cardiac magnetic resonance, as you know, in those cases, or in patients to evaluate comprehensively the right ventricle. Also important, as we will see later, the evaluation of the pulmonary circulation. So for tricuspid regurgitation quantification, very important, these guidelines include the criteria for defining severe tricuspid regurgitation. We are not going into deep on them, but these are imaging red flags that we have to be aware of. And when we find this severity of tricuspid regurgitation, send the patients to these heart valve centers. Also, as I said before, understanding the mechanism and differentiating the different phenotypes, and also for secondary TR, differentiating this atrial versus ventricular tricuspid regurgitation, as previously mentioned. Finally, right ventricular function and evaluation of the pulmonary circulation with cardiac catheterization. Probably this is one of the toughest things. We always look for the magic number. Magic numbers are difficult to find, so it's an integration of different aspects of the ventricular size and function. I have highlighted here in green what could be the more easy, even in a referring center that can be evaluated, and that should trigger our red flag to send these patients and to, in the heart valve centers also, to understand that we are starting to have a really abnormal right ventricle and trying to avoid to go to more advanced diseases where probably the prognostic impact of any therapy is less extensive as compared to an earlier phase. So to sum up, how will all this impact in our practice? Definitely the guidelines, I think they give a big step further on looking right to the right heart. So they give us tips and tricks on how we should look with all this integrative approach, all this multidisciplinary approach, combining multimodality imaging. Transthoracic is, of course, the first imaging tool that should be performed initially in referring centers and then refer for a more advanced imaging in heart valve centers, integrating clinical and imaging red flags. And for sure, there's a lot of education and connection to referral centers that needs to be done in the community, building clinical pathways. And this is why still trying to answer when and who. Probably I would say that now it's better to be earlier, and when we diagnose severe TR, we should moderate severe tricuspid regurgitation, we refer the patient to a heart valve. But it's also important, and will be my last slide, to recognize that we have different stages, different phenotypes, and different options of therapy. And I think this is very important because, of course, the benefit of the intervention may be different in extension, no? But if we are earlier or we are late, but still we have a margin and we have different options for this different presentation at different stages. And I'm sure work will further develop on this. Thank you.
So, Marta, thank you for, first of all, clarifying what the guidelines introduce. And this is actually new. We have seen figures dedicated to tricuspid. You know, in the latest guideline, the previous guideline, there was almost no space for tricuspid, for the workout, for many of these topics. And one of the most challenging topics is actually assessing RV function. But anyhow, let me go again into practice, because on one side there is a guideline, on one side there is a real world. I want to ask Jörg, in your practice, multimodality imaging, we all agree we need multimodalities, but at the end of the day, which one is the most influential in your practice?
Well, there are two. As Martha already elucidated, transthoracic echocardiography is always the first step that we confirm that the patient has severe tricuspid regurgitation, and that we also confirm that we do not have any other valvular disease which might also might be responsible for the situation of the patient. But then in the heart valve center, for us, the most important step is the transesophageal echocardiography, which we need to perform to really understand the anatomy and also to discuss then in our team how we treat best the patient. And this is perfectly done when we see the transesophageal images at the different levels of the heart, which help us then to differentiate which treatment option is best for the individual patient.
And the other question I have for you, Julien, the guidelines don't speak enough, or they don't even speak too much about prehabilitation. This is something we do almost in every hospital, every valve center dedicated to tricuspid. We are very used to do this pre-procedural, let's say, optimization of patients. What the guidelines state about, let's say, optimization of patients for the procedure, for the decision making, what is really the role of this?
It's
therapy?
really important to remind that most patients with TR have functional TR, meaning that it's really load-depending TR. So load will change the severity of TR, but also the size and the function of the right cavities. That's why the guidelines use only two words, euvolemic status. You have to perform the assessment in patients in euvolemia to best assess this patient, at least for the assessment. Then there will be other considerations, so to know how I will improve the outcome of my patient, but it's not mentioned in the guidelines, assessment in euvolemic status.
So that's a very important point. Again, it is all new knowledge which has been brought into the guidelines, and it's somehow the effect of the expertise of the operators, of the physicians who have been involved in this field. And prehabilitation is often important in patients who are in a more severe stage, because we want to make them amenable for treatment. The other point about stratifying risk and selecting patients is about RV function. And whenever we look at assessing RV function, every year there is a new model, new algorithm, new number. Help us, Marta. Is there a way to simplify this question? And the guidelines, are the guidelines somehow simplifying, or they keep a little bit open the door to discussion?
I think the guidelines help in saying that there is no magic number, as you see, because when you see a table with 10 numbers, it means that no one alone is working, of course. And we try to simplify in numbers, but indeed we need to treat more the patient than the numbers, no? I think that's something that we all agree. But I think it has been done a good effort in trying to stratify a little bit what's abnormal in tricuspid regurgitation, because we had data on numbers, a little bit on right ventricular function in other diseases. The problem that we have with tricuspid regurgitation is that 90% is secondary. And from this secondary, we don't have exact numbers, but at least 50% are secondary to a ventricular origin. And that means that it's like in secondary mitral regurgitation. That means that already the right ventricle is impaired. So all these numbers are not going to be useful to indicate the timing of intervention. They might be useful, though, for risk stratification. Mm-hmm. And maybe in the future, maybe we will know in the future that these patients with more advanced stages of right ventricular dysfunction go better with one therapy as compared to the other. We don't know yet. So I think this effort is important from the guidelines. but don't have too much expectations on having one single number. I would say using size, mainly with 2D and 3D echo, which are available tools in our routine practice. I would say annulus of the tricuspid regurgitation, very important to measure in all our patients, particularly if they go for left heart surgery. Don't forget the tricuspid valve annulus. And also, I would say ejection fraction, which is, even if it is visually in experienced eyes, but of course with 3D echo we can do it quite accurately currently. We have good systems of 3D echo now. Of course, in case of that, we have cardiac magnetic resonance, which is the perfect imaging modality because we see perfectly well the endocardium. But still, the numbers are not so magic to indicate or for the timing intervention because of this prevalence of secondary TR. But it helps, particularly in risk stratification.
And regarding risk stratification, I think one element which is still not fully covered by the guidelines is the right heart catheterization and how should be implemented into the process. I will ask then Jörg about this concept. You have been publishing quite a lot in this field. Coupling is something we mention often when we select patients, and so the pressure, the importance of measuring the pulmonary pressure is obviously fundamental, but also the role of the right heart catheterization overall has been rejuvenated by tricuspid intervention. So, what do you think is missing in the guidelines in this respect, Jörg?
Well, let's talk briefly about right heart catheterization and the assessment for the tricuspid valve. What is in the meantime really well known is that patients with increasing pulmonary hypertension, increasing pulmonary pressures, have a worse outcome, irrespective of what we are doing. But still, even patients with high pulmonary pressures can benefit from the therapies which we can apply for reducing tricuspid regurgitation. There is a different, the right heart cath helps us also in diagnosing the severity of right heart, of tricuspid regurgitation. For example, the height of the right atrial pressure, or especially the V wave, is sometimes very helpful to guide our decision making. Another very important aspect is the differentiation between pre-capillary and post-capillary pulmonary hypertension, which is not going to be feasible if we do an assessment or an estimation of the PA pressure by echocardiography. This differentiation is really only possible if we do an invasive assessment, and it helps us to identify those patients with pre-capillary pulmonary hypertension who have probably an even worse outcome than those who have a post-capillary pulmonary hypertension. So for us, it is a very important step, and it is recommended also in the current guidelines that every patient who we are considering for a treatment of the tricuspid valve is receiving such an invasive assessment for our decision making.
Okay, but then after all this discussion, we need to take a decision. So, Jörg, why don't you go forward and you share with us a summary of the new recommendation for treatment?
Yes, thank you very much, Francesco. If I can, here's my slides and my conflicts of interest. So the new guidelines just published a few weeks ago really start touching the entire field of tricuspid regurgitation with the discussion about medical therapy. Medical therapy is primarily the treatment with diuretics, but it clearly states in highlighting this that any medical therapy has a very limited effect on the further evolution of tricuspid severity. And importantly, none of those measures should delay the evaluation of an intervention in a heart valve center. So again, the early referral to a heart valve center is something which is included in the current guidelines. All the treatments, due to the complexity, as we already discussed together with Julian and Marta, these assessments should be performed in a dedicated heart valve center. We need to have these specialists, as we have heard, from EP specialists to surgeons to anesthesiologists to heart failure specialists. Whatever is needed is only going to be available in the heart valve center. So this multimodality imaging, not to forget, this is something we need to reflect in the heart valve center. Risk assessment is also something new in the guidelines, that we have now some dedicated risk scores for our tricuspid patients. The TRI score and the SDS score have been already mentioned, and it is and they help us in our treatment decisions based on the nice work of Julian, published some time ago, really showing that the TRI score is able to guide us a little bit for those patients who have a low TRI score on the left, to the patients with high TRI score levels on the right side. With lower TRI score levels, a surgical and transcatheter therapy seems to be associated with a better survival, while in those patients with high TRI scores, perhaps a transcatheter therapy might be better than a medical therapy alone or a tricuspid valve surgery. Then we have some changes in the guidelines, important changes from the 2021 to the 2025 guidelines, especially now for those patients who have a concomitant mitral disease and who are considered for mitral valve repair. And the previous guidelines mentioned that patients with mild or moderate TR in the combination with a dilated annulus should be considered also for a concomitant tricuspid valve annuloplasty. But this has changed, and there is a downgrading a little bit of this recommendation. Right now, only patients with moderate TR should get a concomitant tricuspid annuloplasty, while those patients with mild TR have only now an indication of a level 2B and a level of evidence of B. So why is that? There is a large randomized clinical trial published in the meantime, just evaluating this concept. And what they saw at 1 and 2 years, of course, there is less TR if you do a tricuspid annuloplasty. But these data did not translate into an improved survival, did not improve quality of life, and did not improve exercise capacity when we're looking at the entire patient cohort. However, if a subgroup is considered with those with mild TR only, this is the upper half of the table, then there was no impact on the primary endpoint, which was a composite of mortality, repeat operation within 2 years, and the progression of TR. While for those patients who had moderate TR to start with, there was a significant reduction in the primary endpoint, and this was mainly driven with the progression of TR at 2 years. So patients who progress from moderate to severe TR in about 14.5% of patients if the tricuspid valve was not receiving a surgery. However, there's a downside of this. The annuloplasty was associated with a 5-fold increase in the need for pacemakers. And we do know that the need for additional pacemakers is also associated with a long-term impact in terms of higher mortality, usually like a 2-fold increase in mortality, a higher risk for heart failure hospitalizations, and also a higher risk for endocarditis. So this is why there is now this very differentiated approach for annuloplasty, and this should be therefore very carefully considered after the evaluation of the risk factors for progressive annular dilatation and progressive TR, and this needs to be balanced against the risk of possible pacemaker implantations. Then there is another very important change in the recommendations, and Francesco, you already mentioned that now there is a 2A indication with a level of evidence of A for transcatheter therapies of tricuspid patients, with a goal to improve the quality of life and the RV remodeling. And this is in patients with severe symptomatic TR despite optimal medical therapy. Now, why is this? Because in the meantime, we have 3 randomized clinical trials with a tricuspid repair and tricuspid replacement, which all 3 demonstrated a significant improvement in the primary endpoint, which was driven by an improvement in quality of life in all of those 3 studies. They did not show in the primary endpoint an improvement in mortality or heart failure hospitalizations, but this is something perhaps we can also discuss subsequently. Now, based on this perfect results of these trials, the current guidelines including also a decision tree for how to treat our patients with surgical and transcatheter tricuspid valve therapies. You see this here on the left side. And for a typical patient, for example, for a patient who is very similar to the study patients, we do see here the pathway which ends in a transcatheter therapy. And this is based, as I said, on these 3 trials. But there are some aspects which have not been studied in the trials. For example, patients with severe right ventricular dysfunction, severe left ventricular dysfunction, or severe precapillary pulmonary hypertension. And this is why the guidance currently only suggest that those patients might be better treated with medical therapy because they have not been studied so far. How do we define this? You have already seen this table by Marta with the definition of severe right ventricular dysfunction by the various parameters. The definition of precapillary pulmonary hypertension and severe left ventricular dysfunction is probably something we do know very well with an ejection fraction of less than 30%. Based on the absence of any data, we looked into our large EuroTR registry to really understand if such patients are truly contraindicated or considered futile for a repair procedure. And in the EuroTR registry, including more than 1,600 patients, there were 213 patients who had at least one of those 3 criteria: severe left ventricular or right ventricular dysfunction or precapillary pulmonary hypertension. Now, of course, due to this concomitant disease, they have a worse outcome. They have a higher mortality at 1 year, as you can see here, compared to those patients who do not have such a concomitant disease. And this is true also if you look at the individual components as shown in the lower part. However, if you now look into the symptomatic improvement, and this is the only aspect which has been evaluated in these 3 clinical trials as a positive endpoint, then we do see that patients, regardless if they have such additional comorbidities, they have almost the same symptomatic improvement than those patients who have not those comorbidities. And again, this is again seen for all those different components of left ventricular, right ventricular dysfunction, or precapillary pulmonary hypertension. So in contrast to the new ESC valvular guidelines, this unpublished work, which I'm presenting here today for the first time, indicates that perhaps we have some patients who might still be candidates for such a therapy, although they might have been seen as a contraindicated patients. However, of course, we need to discuss this very carefully in the heart team and need to do a very detailed patient-shared decision-making in very selected patients. With this, I would love to summarize that the guidelines highlight this early referral of TR patients to heart valve centers, as already discussed. We have a downgrading of the recommendations for concomitant surgical tricuspid annuloplasty in the presence of mild tricuspid regurgitation if there is a planned mitral valve repair surgery. And we have a very strong upgrade of transcatheter therapies for study-like patients. And here we have a 2A level of evidence, A recommendation that such therapies should be considered in patients with severe tricuspid regurgitation. Thank you very much.
Jörg, thank you for the summary. Also, thank you for your criticism. It's interesting to see that obviously in centers with high volumes and particularly having data which is not yet published, you are already one step ahead and you can suggest some adjustments to the guidelines. On the other hand, we need to really realize that writing guidelines is not an easy task. The task force has done a tremendous work to summarize a lot of new evidence. The previous guidelines, almost all indications were supported by a C, opinion-based level of evidence. So on one side, there has been a lot of data which has been accumulated, a lot of evidence which has been generated. I think, again, the PCR tricuspid focus group has been highly involved in this task. And wording are very important. The words that are used in the indication, they're very precise. Class 2A level of evidence A is given to interventions on the tricuspid valve, so includes tear and replacement, no difference. It does not include heterotopic implantation. And the objective of therapy in symptomatic patients is to improve quality of life and to induce reverse remodeling. Now, Julien, you have been studying this concept specifically in your registry. What is the driver for this outcome? How important is to obtain a good TR reduction?
So to date, it has been nicely shown that TR reduction is very, very important, and the lower TR grade you have at the end of your intervention, the best it is for the patient. And if you look, for instance, at the data from the TRILUMINATE trial, they nicely demonstrated that the more they decrease the TR grade, the better is the improvement or the RV remodeling, meaning decreasing of the size of the right heart cavities, tricuspid annulus, right atrium, and RV size, meaning that we have to decrease as much as possible TR after any intervention to at least improve RV remodeling and also quality of life, because the one is associated to the other.
And the other point is about quality of life. Also, the TRILUMINATE also had a linear correlation between, these are really the linear correlation, reduction of TR, remodeling, reduction of TR, and improvement of quality of life. Marta, I've seen your slides regarding medical therapy, and guidelines are lacking in the right heart disease, but this time we see SGLT2 inhibitors suggested as one of the options for these patients. How often you use this in your practice, and how often you see patients with TR coming to you already with this therapy?
I would say that now GLT2 is one of the treatments that we give most to our patients. These ones, and also spironolactone-like diuretics. I think these have the most consensus, even among the heart failure community, to be given in these patients with right heart failure and patients with tricuspid regurgitation. Probably because they are considered HFpEF patients, and then in these patients, SGLT2 inhibitors have been demonstrated that they have a benefit. So in our practice, we give to all our patients, and I think this is the consensus also from the heart failure community.
One quick question to Jörg. I'm a little bit curious. What is your feeling? the downgrade of the concomitant TR angioplasty is supported by one trial evidence, mainly of the risk of pacemaker. But how much maybe in the background of this decision is also the potential for future treatment with transcatheter therapies? What do you think?
Well, I think there is a large opportunity. The benefit is, of course, that we first can wait and see and re-evaluate if the tricuspid regurgitation is reducing after the treatment of the mitral valve. And if it's not reduced over time, then we still have the option of a relatively low-risk intervention with an edge-to-edge repair, for example, to treat the tricuspid regurgitation without the need of a pacemaker in the long term. So like a hybrid approach with mitral valve surgery first, and then re-evaluate and treat those patients in the second step with the transcatheter approach. I think this is very attractive and it might get adopted as a consequence out of those trials.
Jorge, it would be great to keep discussing. I think time is becoming short. We need to see what Saint-Denis did in this particular patient. Let's remind, this was a 72-year-old lady with atriogenic, would say TR, with large annulus, complex anatomy, 4 leaflets. There was a jet coming from all over the coaptation line and also involved in the posterior-anterior commissure, so very challenging anatomy for TR force, probably. What did you decide?
And she was also a low tri-score patient.
Low tri-score, sure.
Very important. So that's why for this patient, we consider a surgical treatment.
Wow. Surprise.
The patient was treated, and she was nicely treated with the implantation of biprosthesis. And at the end, the final result was perfect, and there was no complication. She was discharged without pacemaker with an excellent result.
That probably underlines one factor that we have multiple options. The worst option is not to treat. So and having an excellent result in terms of TR treatment, TR reduction, is probably becoming an important outcome. Jorge, you have shown us the options in the high tri-score sector, so the patients who are at the end of the road. Is there a limit for futility in your practice?
This is probably the most difficult question, which I did hope that I do not need to answer this. It's really very complicated to define futility. There are some risk scores coming out which might help us to define better futility. This is the EuroTR score, which is in the publication process. But all those parameters are not truly a black and white, easy decision making. We have to discuss each patient individually in the heart team to make this decision.
Thank you. I think time is running, and obviously there will be still a lot to be discussed. It's amazing what has been achieved in only a few years. There has been probably the largest increment in recommendations in the whole valve area has been tricuspid, thanks to a community of physicians. Thanks to PCR Tricuspid Focus Group, is a multidisciplinary team with more than 100 members from all over the world, working in a very intense and passionate manner to answer the multiple questions. It's time also to make a summary. What did we learn in this? If we can show this last slide. The 2025 Valvular Heart Disease guidelines put tricuspid valve disease in the spotlight. This is the number one success we as a community obtained. We are very happy that now for a general practitioner there is clear understanding of this pathology. What I think is probably important is class 1 indication. Do not delay referral of patients with TR to specialized heart teams. Specialized centers with all the knowledge around the patient. Delay referral means that medical therapy, we know, can be effective on symptoms for a limited time, but it does not delay the evolution towards overt right ventricular failure and the phase of the so-called futility. And finally, transcatheter interventions received class 2A level of evidence A indication for improving quality of life and to induce reversible remodeling in our patients. However, we learned from Julien, very important that this has to be associated, the procedure has to be associated with an excellent hemodynamic outcome. So you've shown us one case where even surgery still plays a role in these patients. Important to achieve the outcome. Marta, you have been helping us reviewing the central role of multimodality imaging to select these patients and to make sure that we are treating the right ones. And we heard from Jörg what the guidelines are telling us to guide us into the difficult decision-making in a procedure, in a pathology which was somehow forgotten. Now there are even too many options and somehow we need guidance from evidence. So thank you very much, you all, for your attention, and keep posted for the next PCR webinars.